And in the next 15-20 minutes, I will try to give to you an overview about the potentials of immunotherapy in the treatment of early breast cancer. So we have several challenges when we discuss about immunotherapy. First of all is the endogenous immunity. We have features leading to disease eradication versus tolerance. We have a balance between immune response and the capability of the tumor cells to immuno-evade. Then we have stromal elements that can influence the local immunity. Microenvironment matters in this case. And finally, we will move to the therapeutic vaccination. And we have two different endpoints from a therapeutic vaccination. The first one is the immunity. We can induce a monoclonal antibody response without no activity. But the second point is to reset the equilibrium between the immuno-equilibrium and the response against the tumor. So finally, tumor progression and immune response are two parallel ways. We have transformation of cancer cells, we have progressive somatic mutation, and we have clonal evolution in the metastatic setting with tumor heterogeneity. And on the other hand, we have the response of the immune system. In the first step, we have elimination. So if you have a single mutation, the immune system maybe can recognize this single phenotype and can eliminate it. Then we have the status of equilibrium. This is very clear in the case of tumor dormancy. We have some patients with late relapse that can survive for 20 years with a metastatic disease. And this is the case of equilibrium between immune response and tumor growth. And finally, we have the escape. We have so much heterogeneity that the tumor cannot be recognized by the immune system. So finally, eradication and tolerance is a relationship between genome phenotype and the immunome. If a disease is clonal with low heterogeneity, you have much more opportunity to recognize it and to eliminate it. If it is too much heterogeneous, it's not so possible because the immune evasion is a matter. So finally, if we look at tumor heterogeneity and the immunosurveillance, we have a condition of premalignancy in which we should have elimination. That's why maybe in the context of vaccination, prevention is the better setting. Primary prevention, just think about human papillomavirus. Or maybe we can think about vaccination strategy in the CIS. Then we have the condition of equilibrium in which finally you have an immunomodeling. And in this case, you have a balance between the immune response and the tumor growth. But finally, we have the immunosubversion. If the tumor is too much heterogeneous, you don't have any opportunity to eradicate it with the immune system. So you need to think about how to boost the immune system. And what I would like to show to you now is that the two actors of the immune response are finally two cells. It's very, very well simplified here. We have T regulators and T effectors. The T regulators are characterized by the expression of a transcriptional factor that is FOXP3 and by a receptor, the name is CTLA4, that is the target of ipilimumab. And the T effectors maybe are the cells that Fabrice showed in the previous presentation, the tumor-infiltrating lymphocytes that correlate with good prognosis. So if you have much more T effectors in the tumor bed, what we expect is better prognosis because you have a tumor clearance. But maybe you can also have autoimmunity. Just think about the side effects of anti-PD-1 and ipilimumab. They are autoimmunity disease. But if you have a prevalence of T regulators, you have tumor progression. This year in San Antonio, Luca Gianni presented very interesting data from the Neosphere, in which is very clear that a very high level of PD-1 that are expressed on T regulators correlates with residual disease. So much more T regulators you have, much more resistance you have to standard immunotherapy or chemotherapy. What happens when you expose the tumor bed to an anti-CTLA-4 or anti-PD-1? This is a very nice cartoon, and I will show to you. In green, you will find the tumor-infiltrating lymphocytes before and after the exposure. Let me see if I can show to you the movie. Oh, here. So the control, you can see here, you have very limited number of lymphocytes, but after exposure to ipilimumab in green, you have a lot of tumor-infiltrating lymphocytes that can eliminate the tumor. This is very interesting because you can look in this video in vivo what happens. So tumor-infiltrating lymphocytes matter. And we have several evidences in triple-negative breast cancer, in CRB2 positive breast cancer, but also in luminal breast cancer. They can correlate with good prognosis. And also in other tumors like in melanoma, in colorectal cancer, in gastric cancer, when you have tumor-infiltrating lymphocytes, you have a better prognosis. And what's about the microenvironment? This is really a mess, these slides, but just to show that cancer cells produce a lot of tumor chemokines. And you will find in red inflammatory chemokines, in green homeostatic, and in blue the mixed one. Inflammation and cancer, there is a link between inflammation and cancer. And you know that if mutation is the match that fires the tumor progression, inflammation can fuel it like gas. And any one of these tumor chemokines can bind on specific receptors of immune effector cells. So the microenvironment can modulate the immune response within the tumor bed. And one of the examples is the effect of the tumor-associated macrophages. The macrophages are very strange. In the first phase of response against the tumor, they can block angiogenesis, they can improve the immune response against the tumor. But after a short time of exposure to the tumor cells, there is the so-called phenomenon of polarization of macrophages from M1 to M2. And M2 macrophages can increase the proliferation and the survival of the tumors. So they are not so good, they are bad. It's like the Judas kiss, finally. In the first step, they help to recognize the tumor, and in the second step, they increase the proliferation of the tumor. That's why we have potential target on the macrophages. One of these targets can be conventional chemotherapies. 2 weeks ago on Nature Medicine has been published an interesting preclinical study on trabectedin, that is an FDA-approved drug for treatment of sarcoma and ovarian cancer, in which trabectedin can block the polarization of macrophages from M1 to M2. And another interesting receptor is the colon-stimulating factor receptor 1 that is also overexpressed in several breast cancer cell lines, and it is a potential target for breast cancer treatment. These are very interesting preclinical data in which there is a targeting with the monoclonal antibody against the colon-stimulating factor 1 receptor in breast cancer cell lines, that blocking the polarization of macrophage induces dramatic anti-proliferative effects. So let's go back to the vaccination now. What's about the vaccination in breast cancer? We need to drive setting of clinical trial according to the expression of antigens in cancer subtypes. We need to select patients with no or minimal tumor burden, so the ideal setting is the adjuvant setting. We need to perform correlation study between immunological response and the clinical outcome. And finally, it is very important to evaluate the genetic and immunological profile of responders. There are some patients responders, some other not. We had an experience in the adjuvant setting with a vaccine against CRB2. This is a vaccine, the name is DHER2, is a 900 amino acid peptide vaccine that has been injected in patients with breast cancer in the adjuvant setting that did not receive trastuzumab. It's a trial before the era of Herceptin. So this is a vaccination trial in the adjuvant setting. It's a phase 1 trial with 3 consecutive cohorts, 3 dose escalation, 20, 100, and 500 microgram. primary endpoint was the safety, and the secondary endpoint were humoral immunogenicity, cell-mediated immunogenicity, and the impact of escalating dose of DR2. What's about immunological response in these patients? We have 3 cohorts, 15 patients for any cohort, and these are the results. Higher cohort, higher dose cohort, much more immunological response. And what type of response we observed? This is the response against the extracellular domain and the intracellular domain. So you can look here that 90% of patients had an immunological response with the production of monoclonal antibody that can target either the intracellular, either the extracellular domain of CRB2. And what is interesting is that serum of the patient incubated with breast cancer cell lines that overexpress CRB2 clearly can bind the receptor. So these are effective monoclonal antibody. These are the natural trastuzumab, finally. And what's about the T-cell response? But what is important is to demonstrate that you have an increase of T effectors. And also in this case, we have an activation of the immune response in these patients that have been treated within this adjuvant trial. These are other data unpublished from another important large prospective randomized trial. This was a trial performed with another peptide vaccine, Antinuke. Nuke is very overexpressed in breast cancer. In this trial have been included more than 1,000 patients after response induced by a chemotherapy, so with the minimal residual burden. They have been randomized to receive vaccination versus observation. And the authors performed a subpopulation analysis in 350 patients that received endocrine therapy as maintenance therapy, with or without the vaccination. And if you look at this data, there is a dramatic impact of the vaccination in combination with endocrine therapy, respect to endocrine therapy alone, and the parameter is the overall survival. So this is an evidence that the vaccination strategy in the ideal setting can achieve a clinical response. So finally, what is important is to define the appropriate target for a vaccination strategy. And within the Breast International Group and in collaboration with Professor Viale Lab, we tried to discover new potential antigens within subtypes of breast cancer. And you can look here that much more the tumor is heterogeneous, triple negative or luminal B, much more you will find cancer antigens that usually are not expressed in breast cancer cell lines, in normal breast cancer cell lines. We identified 2 potential antigens. The first one is NY-ESO1, primarily discovered by the Ludwig group, and the other one is the Wilms tumor 1 antigen. For both, we have potential vaccine, academic or commercial vaccine. And we tried to design a very nice clinical trial within the Breast International Group in the post-neoadjuvant setting, in patients with residual disease, with triple negative disease. We know that there is a poor prognosis in this population, and we need to have new therapeutic opportunities for these patients. So the trial, the so-called Impulse, designed by my co-investigator, Peter Dubsky, randomized patients with residual disease to vaccination versus observation. It was an ideal setting because you can have a lot of events after surgery, and you can really discover if a vaccination strategy can induce a response. Of course, patients should be triple negative in this case, and WT1 or NY-ESO1 positive. But this is a trial with a long incubation, and actually I believe there is also a tolerance against this trial. And finally, I would like to conclude with the challenges for the immune response. So the first question is, what are the most important determinants of tumor immunogenicity? What are the possible mechanisms by which tumor immunogenicity is regulated? And how can we move forward? So to induce much more immunogenicity, I believe we need to identify the right antigen, and we have to deliver a better efficiency of antigen-presenting cells. But to regulate immunogenicity, we have very interesting drugs. I am talking about ipilimumab, anti-PD-1, anti-PD-L1. They have a lot of potential. They can reverse the immune response in case of progression to a monoclonal antibody. They can boost the immune system. They can be tested in different settings. This was a trial that we designed within the Breast International Group Immunotask Force 4 years ago. It was an idea, before any information about ipilimumab on melanoma breast cancer patients, to perform a tumor biopsy and then to deliver a physical agent against the tumor. This is high-intensity focused ultrasound ablation. This can permit a better antigen presentation because destroy the tumor. And then we give a one-shot ipilimumab, and we evaluate at surgery what happens to the tumor. A similar trial is actually ongoing in the Memorial Sloan Kettering Cancer Center with the cryoablation. It's a proof of concept trial for breast cancer, but we need to have information on what happens. And finally, another way to deliver a better immune response is to educate lymphocyte. You know that there is an only procedure that has been approved by FDA. It's the Provenge drug against prostate cancer. These are lymphocytes obtained from the patients that are educated to recognize the antigen expressed by prostate cancer cells, the PSA. And finally, they are reinfused again to the patient, and they can improve the immunological response. Maybe this is the best way to do personalized therapy, finally. So we have in my conclusion some conclusions, but also critical hurdles. We have to face, every time that we talk about immune response, with complexity of cancer, with tumor heterogeneity, and with the mechanism of immune escape. So we need to explore the activity of these drugs in a very early setting, so neoadjuvant setting or maybe in the adjuvant setting. We have lack of definitive biomarkers for assessment of clinical efficacy of cancer immunotherapeutics. Most of the times we can assess the immunological response, but we have no information on clinical outcomes. Another point is that conventional clinical response criteria do not take into consideration the response to immunotherapeutics. There are the immuno-related RACIS criteria to assess response to ipilimumab. Sometimes you have a response 4 months after exposure and not after 2 months. And what is very important is to disseminate knowledge on immune response. And we have actually insufficient exchange of information that is critical to the advancing on the field. And so I would like to thank you very much, all my co-workers, my mentor, Professor Aaron Goldish, and all the members of the Bing Immunotask Force that are doing a large effort to disseminate everything is related to immune response. Thank you very much.